Hello guys, I'm Dr. Rancham, your pharmacology faculty at Naro, and I welcome all of you to the INI-CET November 2023 questions discussion on pharmacology. And guys, the exam was quite expected on the expected lines. Most MCQs are from previous year's topics. So quick forward, what I've done in this session is some MCQs, some topics I've discussed in detail, like the pre-glycoprotein pumps or MDR1 pumps. So go through this video, and whatever points you get are new, add them to your notes. Irrespective of where you have covered pharma from does not matter. I'll be giving you points which are important for the next INI-CET, which is going to happen in the May or November. Right? So don't watch this video again and again and again. Just watch once, take those points, add to your notes. Right? Now guys, the INI-CET exam heavily relies on the previous year's topics. That is the reason why you need to be damn good in the PYTs of previous year's topics. Right? So at least 3 to 4 years of INI-CET questions. And see, some people, they ask me, sir, the INI-CET exam, I don't want to give because I kind of fear I'll not get a good rank or good marks. And that would kind of demotivate me for the NEET exam. Don't do this. Don't do that. Take the INI-CET exam just as another grand test. Even if you are not fully prepared, even if you have covered only 5, 6, 7, 8, 9 subjects, please go out there, give the exam, and get the real feel of an exam, right? That is precious. Learn about it. Then, while you complete your subjects again in November, then go and get it hard. Take it as grand test number 2. Don't be worried. Then go for DPG. Who knows? God willing, in this grand test 1 and 2, that is INI-CET in May and November, what might give you a seat, right? You never know, guys. Never know. Never ever count yourself out. Always believe in yourself, guys. And what do you say? Let's begin with today's session, right?
All right, guys, let's begin with the first question of this INI-CET November 2023. The first question goes like this. Which of the following drugs can be used in diabetic neuropathy, post-herpetic neuralgia, as well as spinal cord injury? So 3 disorders, and most of these are neuropathic pain related to neurons. Look at the options: amitriptyline, phenytoin, carbamazepine, pregabalin. Now, what could be the answer? Let us try to understand. See, amitriptyline is a TCA, and obviously, tricyclic antidepressants are used in neuropathic pain. But amitriptyline, it can be used in diabetic neuropathy. I can use it. I can use it in post-herpetic neuralgia, right? So 2 uses are possible with this, but spinal cord injury associated pain is not one of the uses, right? Pain is not one of the uses. Phenytoin and carbamazepine, they are also used in neuropathic pain, but which one? Can you think of one use of these anti-epileptics in neuropathic pain? This is trigeminal neuralgia, right? Trigeminal neuralgia. Whereas pregabalin can be used in diabetic neuropathy, post-herpetic neuralgia, plus spinal cord injury associated pain. For all of these 3, I can use pregabalin. So pregabalin is the best possible answer here. The second closest comes is amitriptyline. So pregabalin, how to remember what are the uses of pregabalin? See, pregabalin, if you look at pregabalin, let me write here. Pregabalin, right? So from pregabalin, in this word, we'll pick up 2 words, P and N, right? P for partial seizure and P for peripheral neuropathy, that is seen with diabetes mellitus most of the times. N for, we can remember, it is used in neuropathic pain. And what are these neuropathic pain? These are post-herpetic neuralgia, spinal cord injury associated pain. I can also use it. So these are 2 of the neuropathic pains. Now, one pain that it can be used is not exactly neuropathic pain, but it is a pain syndrome that is called as fibromyalgia, right? So this is another use of pregabalin. So from P and N, we can remember the important uses of pregabalin. Like pregabalin, they do not give you the option. They can also give you gabapentin. So pregabalin or gabapentin, they act by these mechanisms, right? So question number 1, guys, the answer is pregabalin. I've taught you this in your Mero videos. If you've gone through them, you can answer this. Sodium valproate has an inhibitory action on which of the following sites? So one of the things they ask in pharma, see, there are not lots of images in pharma, isn't it? So what they do is they try to make images out of the mechanisms of action, and then they ask MCQs out of those. So if you look at this image, particularly sodium valproate, let us remember, what have we talked about sodium valproate? It's a calcium channel blocker, isn't it? It's also a sodium channel blocker. Plus, it also increases GABA. How? By inhibiting metabolism. So these are the three important mechanisms of action of GABA, right? Now, if I look at this, in this pathway, GABA is being synthesized, and two enzymes involved in GABA synthesis are GABA transaminase, which is blocked by vigabatrin, and succinic semi-aldehyde dehydrogenase, that is the one that converts also for synthesis of GABA, right? So these are two enzymes which can be blocked by, these two enzymes in B can be blocked by valproate. So here B is the right answer. All right, so see, this type of MCQs will be asked. If you know the mechanism of action, the images are not difficult to answer. You just have to correlate whatever you learn in words to the images, and that's it. Now, coming to one of the important MCQs, which is asked only and only in INI-CET. This is asked by the AIMS guys. Which of the following drugs act by ATP binding cassette transporter? Now, this is the options are verapamil, diltiazem, nifedipine, amlodipine. I'll take some time on this topic. Now, if you have covered from Mero lectures, you know this topic, right? I've taught you. But if you have not covered from Mero lectures, in this few slides, I'll try to explain to you what are these ABC pumps. See, ATP binding cassettes, these are called as ABC pumps, right? And ABC pumps, three of the important ABC pumps are, number one, it is called as P-glycoprotein pump, or it is also known as MDR pump, MRP1 pump, and BRCP pump. Now, out of these, the most important is this one. And MCQs are always asked on P-glycoprotein pump or MDR pump. Now, first of all, a P-glycoprotein pump or MDR pump, what are the substrates? What are the substrates for this pump? Which drugs this pump can excrete, right? So how to remember? All right. So I'll tell you a technique, how to remember which drugs are substrate for MDR pump. Let us do one thing. To remember this, let us first write down M, then D, then R. So which drugs are substrate for MDR? To remember that, I'll use an interesting technique here. Like, let us use the alphabets before these alphabets, like L, M, N, C, D, E, Q, R, S, right? So this will give us a list of the most important drugs which are substrate for MDR1 pump, right? Which are substrate for MDR pump. So MDR or P-glycoprotein pump. What are the drugs here? L for loperamide, M for morphine or methadone. So these are the opioids, all of these three drugs, right? N for nalfinavir, C for is an antibiotic, that is clarithromycin. Plus we have an immunosuppressant from C. Which one is that? Cyclosporin, right? So C for cyclosporin as well. D for the single most important drug here, D for digoxin. E for erythromycin, erythromycin, you know, they always go hand in hand. Q for quinidine, R for rifampicin, and S for statins. So first thing, you need to remember which are the substrate for P-glycoprotein pump or MDR substrate. So which drugs can undergo efflux by this pump? So I've told you mechanism how to remember these drugs, right? Now, what is the relevance of these drugs? Let us try to understand. See, suppose this is one of the intestinal epithelial cells, right? And a drug is undergoing absorption by passive diffusion, and then it goes into your systemic circulation. This is how a drug is absorbed in your intestine, right? This is your intestinal epithelial cell. Now, for some drugs which are subset of P-glycoprotein pump, suppose this is a PGP here, right? P-glycoprotein pump. Some drugs, what will happen is the drugs will be absorbed. Suppose these are the molecules of drug absorbed here, right? So a lot of drug will get absorbed, but some of the drugs will not get absorbed. Rather, they would be thrown back into the intestinal lumen. And this is what is done by this P-glycoprotein pump. What's happening here is called as drug efflux. It is called as drug efflux that happens in your intestine. It can happen in liver, and it contributes to first pass metabolism as well. So just imagine if I have two substrates. For example, if I have this drug is clarithromycin and digoxin, two drugs, I told you the substrates. Here you can see clarithromycin and digoxin. Then in that case, what is going to happen? Clarithromycin can cause inhibition of digoxin efflux, right? This efflux, clarithromycin will block this efflux of digoxin and will cause digoxin toxicity. So if I give clarithromycin, it can cause digoxin toxicity. So guys, these are the previous year's questions of INI-CET which have been asked. Similarly, if you can look at here, statins are also subset for these pumps. So if I give clarithromycin, it can also cause statin toxicity. So these are two MCQs which have been asked, right? And it is related to the P-glycoprotein pump. All right. So they can competitively inhibit with each other. Now, enzyme inducers can induce this pump. Right. So enzyme inducers, for example, let us talk about rifampicin. Rifampicin is an enzyme inducer, right? Phenobarbital is an enzyme inducer. So these enzyme inducers will increase the number of pumps as well. And for example, if I ask you what rifampicin or phenobarbital can do, they can cause digoxin failure. Right? So these are things which will happen at the level of intestine when the drug is getting absorbed. Clarithromycin can cause digoxin or statin toxicity. Rifampicin or phenobarbital can cause digoxin failure. So these, whatever is seen, is just like enzyme inhibition or enzyme induction, right? Apart from this, what else have been asked and what else is related conceptually here, we'll try to understand. Apart from intestine, let us suppose this is our hepatocyte, and from this hepatocyte, bile acid is secreted by this pump called as P-glycoprotein pump. They also secrete bile acid. And see, drugs are also secreted by this pump, right? So drugs can inhibit bile acid secretion and cause cholestatic jaundice. They had asked you which drug. The drug was in the option was cyclosporin. So cyclosporin can cause cholestatic jaundice, right? By inhibiting which pump they had asked? P-glycoprotein pump, but P-glycoprotein pump was not in the option. Another pump was in the option. What was that pump? Let me try to explain. Suppose I take a bacteria, or let us take a cancer cell. So let us take a bacteria or cancer cell. If this is a bacteria or cancer cell, then usually what happens, whenever you give a drug, the drug will enter into the bacteria or cancer cell, and obviously the bacteria or the cell would die. Nobody wants to die. So what this cell would do, it would produce P-glycoprotein pumps, which would throw these drugs back into your systemic circulation. And this is again called as drug efflux, and this will cause drug resistance. So resistance in bacteria, in cancer cells, can be due to drug efflux. So before this, I talked about drug efflux was physiological in your intestine. Here I'm talking about drug efflux where in pathological cases, like in the bacteria or the cancer cells. All right. What because there will be resistance. These peak glycoprotein pumps, they're also known as MDR1 pumps. MDR is multi-drug resistant 1 pumps. So when they ask you, so PGP is equal to MDR1 pump, so then they ask you MDR1, they'd ask you cyclosporine causes cholestatic jaundice is because of block of which pump? Which pump? Your answer was MDR1 pump. Your answer was MDR1 pump, right? All right, so this has been asked. Now coming to the reversal of bacterial cancer resistance, the drug that is being tried is how can I reverse this resistance? Suppose if I block this P glycoprotein pump, then I can reverse the resistance because drug would not undergo efflux. So how can I block P glycoprotein pump? The drug that I use here for trial is verapamil. So most commonly drug that has been used to reverse resistance is verapamil, to reverse resistance either to antibiotics or anti-cancer drugs. So guys, these are a few points which have been asked, and our MCQ is precisely based upon this point. Which of the following drug acts by ATP binding cassette or ABC pump? One of the examples is P glycoprotein pump or MDR1 pump. And what is the answer here, guys? The answer is verapamil, right? Answer is verapamil. Now here there is one more point I'll explain to you which they can ask. See, for example, if I look at loperamide, if this is my blood-brain barrier, and if I give loperamide, usually loperamide has no CNS action, but it crosses the blood-brain barrier. Then why no CNS action? The reason being, again, what do we have? We have P glycoprotein pumps. So what they do, they throw the drug, back from the blood-brain barrier. And this is the reason why you do not have CNS effect. Now, what if I give another substrate that would block this P glycoprotein pump like quinidine? All right, is quinidine a substrate? Let us see. Is quinidine a substrate? Yeah, it is a substrate, right? Suppose I give quinidine with loperamide. What is going to happen to the patient? This loperamide will not come back from the brain via P glycoprotein pump, and then you'll have CNS toxicity. So if I combine any of these substrate for PGP, they would cause CNS toxicity of a drug like loperamide. And what is that I'm worried about? It being an opioid. What I'm worried is about respiratory depression. What you might be thinking, sir, why did you give the example of only quinidine? The reason why I gave example of only quinidine, because this is what is given in Goodman-Gilman, that quinidine can cause respiratory depression if combined with loperamide as an example of block of P glycoprotein pump. So that can be asked. So guys, whatever other scenarios I have given to you guys here, and it is a specific topic for INI-CET, right? So we're preparing for INI-CET. NEET PG, they don't ask these stuffs, right? Now coming to the next one. Which of the following pathogens is correctly matched to this intrinsic drug resistance, right? Aspergillus niger, voriconazole, Candida krusei, fluconazole, Candida glabrata, amphotericin B, Sporothrix, itraconazole. It's a repeat MCQ. Plus, I've taught you this, that whenever I say, now if you remember in my lectures, I tell you this statement from the beginning. Whenever I say fluconazole is a drug of choice for Candida, just recall the video lectures. I tell you, Candida does not mean all Candida. It means only one species, that is albicans. So whenever I say fluconazole is a drug of choice for Candida, it means only albicans. So Candida krusei, fluconazole will not be the drug of choice. Second, if I say fluconazole is a drug of choice for Candida, I do not mean all forms of albicans Candida even, right? It means only mucocutaneous. Right. So these are two things you have to understand. So for example, mucocutaneous means what? Mucocutaneous means what? If it is the case of vaginal esophageal candidiasis, cystitis due to Candida, your drug of choice will be fluconazole, right? But if it is oral candidiasis, then your answer is clotrimazole. Clotrimazole lozenge. So lozenge, these are like toffees, right? They will dispose in the mouth, would have local effect, more efficacious. So what about non-albicans candidiasis like krusei, glabrata, parapsilosis, all of these, tropicalis? Or what if it is a case of invasive candidiasis, even if it is caused by any candida, including albicans, including albicans? Now, in this case, like for example, invasive candidiasis, for example, if there is a patient who comes to you with candida meningitis. Now, here my answer will not be fluconazole. Here, my answer would be echinocandins. Echinocandins are the drug of choice. Echinocandins are the drug of choice. Alternative, I can use amphotericin B. I can use amphotericin B. So, guys, this is in nutshell treatment of candidiasis. So here you can see Candida krusei fluconazole is wrong. Glabrata amphotericin B can be used as an alternative, but the preferred drugs would be echinocandins. Aspergillus, drug of choice is voriconazole. How I teach in the class, reverse A, you'll get V, voriconazole, right? And sporothrix, so sporotrichosis, if you remember, I've taught you this, itraconazole is the drug of choice. So either you could have ruled out, or you can directly solve this MCQ by one point, that fluconazole is drug of choice in Candida, condition applied only for albicans, nothing else, right? Guys, moving on to the next question. A patient on fluoxetine was started on pain control drug for neuropathic pain. He developed an episode of syncope after 2 weeks. ECG revealed QT interval of 477 milliseconds. Which of the following is causative drug? All right. First of all, you have to understand here, the fluoxetine drug is important because it can cause QT prolongation. He was already on a drug that causes QT prolongation, and now he was started on a drug for treatment of pain that worsened it. Which one is this? I've taught you this. I've taught you only about one opioid that can cause QT prolongation, and that is methadone. Methadone can also cause QT prolongation, right? Can also cause QT prolongation. So I have told you this, QT prolongation or torsades is a very important topic for any exam, right? NEET, PG, FMG, INI-CET, does not matter. So can I remember few drugs that can cause QT prolongation? Quinidine, class 3 drugs, that is potassium channel blockers. Quinidine is a class 1A. So it is 1A drugs, quinidine. All right, Q for quinidine. Q for quetiapine, it is an antipsychotic. Q for quinidine, Q for quetiapine. M for methadone. F for fluoroquinolones can cause QT prolongation. Maximum it is seen with moxifloxacin. Right, moxifloxacin, it can cause QT prolongation. Plus M for macrolides. So these are the few examples of drugs which can cause QT prolongation. And obviously, SSRIs can also cause QT prolongation. So obviously, here it is a case where the patient was given SSRI along with methadone, and that is the reason why the patient had syncope, right? So the answer is methadone, pure and simple here, guys, right? Now moving on to the next question. Which of the following is beneficial in reducing painful crisis of sickle cell anemia? Again, it is a repeat MCQ. This has been asked both in NEET PG as well as INI-CET. Look at the options: hydroxyurea, methotrexate plus leucovorin, methionine, L-thrombopac. What do you think is the answer? It's a simple one, guys. The drug of choice for sickle cell disease is hydroxyurea. Hydroxyurea, it is also drug of choice for polycythemia vera, essential thrombocythemia. 3 uses of hydroxyurea. Right. Side effect of hydroxyurea that is commonly asked in your exam is leg ulcer. These are very painful leg ulcer that can be seen. This is another MCQ they ask. So if you are studying hydroxyurea for your exams, 4 points you must know. Hydroxyurea is the drug of choice for sickle cell anemia. Number 2, it is drug of choice in polycythemia vera. Number 3, essential thrombocythemia. Number 4, it causes a side effect called as leg ulcer, right? All right, guys, moving on. Which of the following mood stabilizers causes hepatotoxicity and hypoammonemia? Guys, it is an easy one. I have told you about this. The answer is valproate, right? So valproate can cause both hepatotoxicity as well as hyperammonemia. And for both of these, what is the antidote of choice, guys? Let me know in the comment box. What is the antidote of choice for hepatotoxicity and hyperammonemia caused by valproate? Guys, the antidote is carnitine. The antidote is carnitine. So this has been asked. So valproate is an important drug, guys. They love to ask about valproate because it is quite a commonly used drug, not only in epilepsy, but also in case of bipolar disorder. Last time I said they asked you which is the most teratogenic drug in bipolar disorder. Again, your answer was valproate. So valproate is the most teratogenic drug, not only in bipolar disorder, but also in epilepsy, right? Right, guys. So this was an easy one. Next, which of the following is most useful drug to treat doxorubicin-induced cardiotoxicity? See, D for doxorubicin, induced cardiotoxicity, I use D for dexrazoxane. So why dexrazoxane is the answer here? See, doxorubicin produces free radicals, and both doxo and daunorubicin, they produce free radicals, and that is responsible for cardiotoxicity. So free radicals are responsible for cardiotoxicity, and these free radicals, they need iron. They need iron to be produced. Anyways, free radicals are good for the drug because they will kill the cancer cells, but they're bad because they will affect your heart, right? And what they do is cardiotoxicity. They cause vacuolar degeneration of the myocardiocytes, right? So what to do to prevent or treat this? I would obviously chelate iron. So I'll give an iron chelator. Which is the iron chelator? Dexrazoxane. As simple as that. So if they ask you, simple, remember, D for doxorubicin, D for daunorubicin. What is the antidote? D for dexrazoxane, which would antagonize or chelate irons, right? Next, all of the following side effects are more commonly seen with carbamazepine than oxcarbazepine except. So again, this is an easy MCQ. This has been asked multiple times, not only in INI-CET but also in NEET PG. Which one is that, guys? So I told you, oxcarbazepine was synthesized so that it would be lesser toxic as compared to carbamazepine. But we succeeded. Oxcarbazepine causes lesser hypersensitivity and lesser of life-threatening side effects like aplastic anemia, agranulocytosis. I mean to say hypersensitivity all in all. But with this, something unexpected happened, and that is there was a high incidence of hyponatremia. So if this is a plum MCQ, so the uses of carbamazepine, oxcarbazepine is exactly similar, and because of this high risk of hyponatremia, it should be contraindicated in elderly patients because hyponatremia is more common in elderly group. Second thing, remember, hyponatremia is a delayed side effect. It's not an early side effect. So hyponatremia, 2 MCQs are asked, right? One, where it is more commonly seen, which age group? Elderly, right? Is it an early or delayed side effect? Your answer is delayed. Second, why they cause hyponatremia? Hyponatremia is because of SID. So they ask, what is the type of hyponatremia? It is a dilutional hyponatremia. The reason being, it means what? The amount of sodium in the body does not actually decrease, but the amount of water increases because of increased secretion of vasopressin, and relatively that decreases sodium as compared to plasma. And that is what is called as dilutional hyponatremia, right? Other things can be seen, rashes, blood dyscrasia, hepatitis, all of these, they can be seen with carbamazepine. All of that we have decreased with oxcarbazepine. Excellent drug, excellent one, except hyponatremia, right? Alright guys, now let's move on to the next question. A 12-year-old boy presents with complaints of profuse watery stools and elevated WBC count of 16,000, right? He has been treatment with amoxicillin for past 1 week. What is the treatment of choice for this condition? Now see, this patient was on amoxicillin for past 1 week, and what it does, antibiotics, they suppress our normal gut flora. And because of suppression of normal gut flora, there is an increased application of pathogenic bacteria, like, for example, in this case, Clostridium difficile. Increased growth, and that causes a disease called as pseudomembranous enterocolitis, right? So this is what has happened in this patient. He has developed profuse watery diarrhea, elevated WBC counts. The patient has developed pseudomembranous enterocolitis. And the question is asking, what is the drug of choice? All right, let us see. Pseudomembranous enterocolitis, how do we treat? If you look at the clinic, you have to first find out if it is fulminant or non-fulminant. If it is non-fulminant or it is fulminant. If it is a case of fulminant, then I'll be using oral vancomycin plus IV metronidazole, right? Fulminant cases. If it is non-fulminant and if it is first episode, then the drug of choice would be oral fidaxomicin. How does it act? We've discussed this in the section of antibiotics. It acts by inhibiting RNA polymerase. This drug was designed specifically for treatment of pseudomembranous enterocolitis. First episode. All right, what if it is second episode? What if it is second episode? Or I would call it as first relapse. So what if it is second episode or if it is a first relapse? In this case, what I'm going to do is the treatment would depend upon when was second episode seen. Was it seen in a time period of more than 6 months or less than 6 months? If more than 6 months, treatment is exactly same. Less than 6 months, slight change. What is that change? I'll be again using oral Redaxomycin plus I'll be using Basilitoxumab. Basilitoxumab is a mAb against TOX, toxin. Which type of toxin? Toxin B of which bacteria? Of bacteria Clostridium difficile, right guys? So this is treatment of pseudomembranous enterocolitis. All right, I've told you in detail about how it is treated, but you can see here the MCQ is not that difficult. All right, this is a case of pseudomembranous enterocolitis. What is the treatment of choice for this condition, guys? You can look at the option A, B, C, D: fidaxomicin, clindamycin, zanamivir, cilastatin. It's an easy one, guys. Two of them are nowhere close to treatment. Now A and B. Now see, these two are bogus options, right? Antiviral drug cilastatin is used with imipenem as a blocker of renal dihydropeptidase. Clindamycin is not the answer because it causes pseudomembranous enterocolitis. It is one of the potent causes, right? The answer is fidaxomicin. The answer is fidaxomicin. Now, why they have given you amoxicillin here? See, usually the most common cause of pseudomembranous enterocolitis are third generation cephalosporins, followed by aminopenicillins. So third generation cephalosporins followed by aminopenicillins, these are the preferred drug, right? All right, now moving on, guys, to the next question. A patient on amitriptyline was found in unconscious state. Which of the following does not suggest amitriptyline toxicity? Look at the options: arrhythmias, confusion, hypothermia, mydriasis. All right. Do you remember with TCA or tricyclic antidepressant, I talked about only few things, that the side effects would be because of block of other receptors. All right, what are these other receptors? These are muscarinic. Okay, muscarinic. What else? H1. Okay, what else? 5-HT. Okay, what else? Alpha 1. Right? So all of these block. For example, if I block muscarinic, there would be mydriasis, constipation, plus block of muscarinic would block sweating and there would increase temperature. In other words, there would be hyperthermia. H1 block will cause sedation. H1 5-HT block will cause obesity. Alpha block will decrease blood pressure. That would cause what? Postural hypotension, right? And TCA, because of the muscarinic block, they can also cause arrhythmia. Now, all of these side effects I've discussed this in the lectures. Just go back and see how easy this MCQ was when they asked you, which is not found. Arrhythmia, confusion, hypothermia, mydriasis. Answer is hypothermia. It will not cause hypothermia. It will cause hyperthermia, right? Hyperthermia. Amitriptyline toxicity, the death is usually seen due to arrhythmia. But here, remember, sorry, I marked wrong. It is not the answer. Answer is hypothermia. Death would be seen due to arrhythmia. And the antidote for amitriptyline toxicity is bicarbonate. Bicarbonate is the antidote of choice. Bicarbonate is the antidote of choice. All right, guys. So plain and simple, answer is hypothermia, right? A 40-year-old woman with multi-drug resistant TB presents with fatigue, constipation, weight gain, neck swelling. Just combine all of these and try to find out which disease are we talking about. Which is the disease? Fatigue, constipation, weight gain, neck swelling. Which disease is this? Which disease, guys? Hypothyroidism. Now again, this is a PYQ that has been asked in the AIMS exam. So this is an MCQ, again, found by the AIMS exam in the INI-CET. Hypothyroidism can be caused by which of the following drugs is what this MCQ comes down to. Paracetamide, ethionamide, cycloserine, streptomycin. What do you think is the answer, guys? Ethionamide. So if you have solved the PYQs, you'll be able to solve. So see, for INI-CET exam, you have to do the PYQs. PYQs are very important for INI-CET. It has always been for the Central Institute exams. The MCQs always revolve around the PYQs, right? All right, now guys, moving on to the next question. Which of the following antibiotics act by inhibiting 50S ribosome? Now say 50S, which one do you think is 50S? Remember, I told you 30S is blocked by two drugs which act upon the A side, and these were tetracyclines and aminoglycosides. 50S is blocked by all other. All other they block 50S. 30S is blocked by only those drugs which act upon A side, tetra and aminoglycoside. Now out of these, which are protein synthesis inhibitor? You can see here, aztreonam is not a protein synthesis inhibitor. Daptomycin acts upon cell membrane. Linezolid, rifampicin are protein synthesis inhibitor. Rifampicin, it is a blocker of RNA polymerase, right? It's an NADP drug. So the drug that is left here, that blocks protein synthesis, is linezolid. So all the drugs that block 50S, like linezolid, macrolides, streptogramins, and clindamycin. So all of these are inhibitors of 50S, right? So linezolid is an MCQ, and this is not a difficult one, guys. All right, next question. An elderly patient with dementia is not compliant with oral medications. Which of the following will be beneficial in this case? Now, this is a damn difficult question. And I'm telling you, this MCQ has not been formulated by a pharmacologist. It has been made by a neurologist who actually sees cases on daily basis in India. Why? I'm going to tell you. Remember, memantine is oral only drug. These three are oral as well as transdermal. Transdermal, three of them can be used worldwide, but transdermal in India, the only one available is rivastigmine. Rivastigmine. Right, now look at this question. Elderly patient dementia not compliant with oral drug, obviously. So I'll go for transdermal. I'll give one patch, and which will be the following beneficial in this case. So obviously, donepezil transdermal not available in India, galantamine not available, memantine, there is no transdermal. So the better answer here is rivastigmine. All right, now what should I do for such kind of MCQs? Should I feel bad if I'm not able to solve such MCQs? No, you should not, because these are difficult not only for you, but for everyone. So these are not the rank deciding questions. But yes, if it is repeated, I should be able to solve it within few seconds, couple of seconds, right? All right, guys. A patient with hemophilia on antiretroviral therapy is brought to the alternate mental status following complaints of nausea, vomiting, and headache. Antiretroviral therapy, which of the following medications was he taking? All right. So here the answer is tipranavir, and I have taught you this. It has anticoagulant effect. Anticoagulant effect, and that is the reason why it can cause intracranial hemorrhage. So tipranavir, that is the reason why we don't use it. We don't use it. So tipranavir, I'm surprised they asked you this MCQ because it is unnecessary, because the reason we don't use it. So why do you ask? Why don't you ask about lopinavir or ritonavir or darunavir, which is used, right? But anyway, see, this is an exam. Sometimes they ask MCQs which is not related to our day-to-day practice. So anyways, the answer here is tipranavir. We've discussed this in the Mero videos, right? A 25-year-old male patient presents with severe purpuric skin lesions and is diagnosed with ITP, right? Which of the following tyrosine kinase inhibitors can be used in this condition, right? Let us see. If there is a case of ITP, in that case, then the drug of choice is either we use steroids or we use IVIG. If there is no response, then I can use thrombopoietin agonists. Which are these drugs? Like L-thrombopag and romiplostin. Or I can use a spleen tyrosine kinase inhibitor called as fostamatinib, or I can use rituximab. It can be used. Or we can go for the most radical treatment, that is splenectomy. Right? So remember the treatment of ITP. Whatever MCQ they ask you, it would be in and around this. What if they asked you, which of the following is a tyrosine kinase inhibitor? See, all of them can be used except bosutinib, right? Except bosutinib, right? Bosutinib is used in CML, chronic myelogenous leukemia. So here A, B, and D, all of them can be answered, but D is the right answer here. Why D is the right answer? Because they're asking about what? They're asking about a tyrosine kinase inhibitor, right? So this is a stupid MCQ. I'll tell you why. Why this is a stupid MCQ? Because the moment they mention tyrosine kinase, these two are out. These two are out. Because see, tinib, it means what? Inhib is inhibitor. T means tyrosine. So T means tyrosine kinase. So tyrosine kinase inhibitor, there would always be tinib. So two options you could rule out just by this. Left with two. If you know that bosutinib is a drug used in CML, you're left with which one? Fostamatinib, that is an inhibitor of spleen tyrosine kinase. Now see, many times in competitive exams, it is not always about knowledge. Even if you don't have knowledge, you have to be smart. And by your smartness, you can outperform yourself, right? So see how I told you, right? So guys, this is the last question for today. Which of the following newly approved anti-diabetic drugs can be given for heart failure with reduced ejection fraction and impaired renal function? Now, if you remember, for this, I have given you a mnemonic SHIVA Shiva beta. So I'll not tell you all the drugs. So any drugs which can be used in chronic CHF, heart failure to decrease mortality. And as for, I had given you one class of drug called as SGLT2 blockers. It was in the mnemonic, right? And we have to find out which is the SGLT2 blocker diabetes here. It is empagliflozin is an SGLT2 blocker. So empagliflozin, I told you this, they will ask you this. They'll ask you this, right? So this was asked recently in the exam. This is not difficult. So guys, I've told you time and again, your right marrow notes are gold standard. If you know master your notes, and in each and every page of the lecture, I tell you what to remember, what not to remember, you'll get most of the answers as right. And while going forward for your INI-CET exam in the May or in the November in 2024, always remember, please do go through the last 3 years PYQs at least. The topics, master those topics. It is not always about PYQs. It is about PYTs, previous years topics. As you can see, the topic I told you, ABC, ATP binding acid, P-glycoprotein, MDR1 pumps, how many MCQs have been asked, but the route is same. So you have to catch the route, right? Not the branches, right? Because the branches keep on changing. The route will remain the same. That happens with all the central institute exams. If you're going to give central institute exam, never think that you are not made for it. Anyone can do anything in life. The only thing is you need to believe in yourself, right? Don't take much stress on the INI-CET exam. A lot of people, they ask me, sir, I'm not well prepared. So I kind of don't want to give the exam because if I don't score well, I would be demotivated. In that case, I tell them, don't give the exam thinking that I'll get a seat. Give the exam, take it as just another grand test. So give the INI-CET just as another grand test and just see what happens, right? Be cool, be chill. All of us know, we know that maximum chance of getting a seat is in the NEET PG exam. That will happen sometime later. But why not try my level best and give my best in INI-CET May? If I flounder, it's okay. There will be another INI-CET November. So I learned from my first failure what to do in the second failure, November. So take INI-CET May as one grand test, November as second grand test. And God knows, maybe possible, you might get a rank through this grand test as well, and you might not have to give the NEET PG exam. Anyways, so I'm kind of an optimistic person and always take optimistic view of life. So guys, this is what I had to discuss in the section of recall, and my best wishes to all of you, and may God give you whatever you desire in your life. Take care, guys. Bye bye. This was Dr. Ranjan.